Good evening, students. Good evening, students. Please let me know if audio and video are fine. We can start. I want all of you to join in. This is an interactive MCQ session. So I'll just wait for 2 minutes so that everyone joins in and then we can start. Please let me know in the comments if you all are here. Good evening, Monirudha. Rest. Please let me know in the comments. Fine. Shall we start? So again, in today's session, I have about 15-16 questions. Good evening, Alia. I have 15-16 questions for you all. Alright. So I'll read out the questions along with the options. I want you all to answer in the comments down below. Write your question number along with your answer. Good evening, poor boy. Okay. Fine. I'll read out the questions. The options. Take 2 minutes to reflect. Tell me your answers in the comments along with the question number. Don't worry even if you get your answers wrong. I'm here to correct you and tell you how it is to be approached. Alright. So let us start with our first question. A patient arrives in the emergency room confused, disoriented, with slurred speech. What triage category would you assign them? Option A is yellow, B is red, C is green and D is black. So let me know your answers and then we'll discuss. Okay. Good evening, Neha. Okay, can I have more answers? I want whoso all are viewing have joined me, joined along with me live in this session. Please don't hesitate in answering. Participate. Let us make this an interactive session. I want all of you to answer here so that your mistakes are corrected. Alright. And in case if you're giving the right answer, you get more confidence. And in case if you are not able to understand something, you're able to understand something correctly. Okay. So answers please, more answers. Then we'll discuss. Okay. Fine. Let us now have a look at the question and how are we going to interpret it. Okay. Now, it says a patient arrives in the emergency room confused, disoriented, with slurred speech. Okay. Now, there are, I'll tell you, triage is applicable at 2 places. Okay. So, when a person is confused, he is disoriented, there is slurred speech, you will mostly think in terms of a stroke. Alright, in terms of a stroke. And what is your stroke? In very simple terms, it is nothing but maybe an intracranial bleed. Alright, so such kind of patients need urgent care. To minimize our neurological deficit, we need urgent care. Alright, to minimize the neurological deficit, we need urgent care. So the correct answer here is red. Alright, the correct answer here is red. Alright, to all those who have answered yellow, is it understood? Okay. So now, quickly, I'll tell you two things about triage. We all have revised triage a lot. Okay. We know the categories, we know the color codings, but there are two things. One is triaging at the site of a mass casualty. Okay. Either a train accident, a bus accident, an earthquake site. Alright, one is triaging at the site where the mishap has happened. Second triaging is when a patient walks into the emergency room of a hospital. Alright, so many international level emergency rooms, they have color codings on the floor. Their areas on the floor are divided. Red, these particular beds, they have tapings on the floor, that they have boundaries drawn on the floor that all beds within this red tape fall under red category, triage beds. Then they have few beds in which the boundary they have taped as yellow, so those beds are yellow and green. So like this. Alright, so here the situation was the patient has walked into triage. How will you categorize him? So this patient is probably having a stroke, so it needs urgent care, hence the triage category red. Okay, let's move on to our next question. I hope it is clear to all who have answered yellow. The next question: a dentist removes a maxillary premolar and notices that he or she has created an oroantral communication which is 4 mm in diameter. Which of the following is an appropriate treatment? So option A is no surgical treatment. Option B is figure of 8 sutures to maintain integrity of the blood clot within the socket. C requires a buccal fat pad flap advancement, and D tongue flap advancement. So what would be the answer to this question? Please let me know. Okay, yes. So yes, it is correct. The answer here would be option B, that is figure of 8 sutures to maintain the integrity of the blood clot within the socket. This is the correct answer. So good. Almost all of you have gotten it correct. Okay. Now, just to tell you all that whenever the question is in terms, or when the diameter or the dimension is given in terms of 5 mm or 0.5 centimeters, then you will answer as per the older concept which I have told in my class. And whenever there are values which are given other than 5, then you'll answer as per the newer concept, in which we divide the dimension into less than equal to 2 mm of communication, 3 to 6 mm of communication, and more than 7 mm of communication. Alright, so just to quickly run through it, less than 2 is you observe the patient, you don't do anything, you keep the patient under observation, under follow-up. After 2 weeks, you see if it is still persistent, the communication is still persistent, you go for closure. Alright, in 3 to 6 mm, you use your aim is to organize and stabilize the blood clot and suture it. So either you pack a gel foam or Surgicel, something you pack in there, and you close it with sutures. and if it is more than or equal to 7 mm, then you require flaps for closure of the communication. Okay. Now, the next question. Signs of close proximity of the mandibular third molar to the inferior alveolar canal are: option A, darkening and notching of the root; option B, straight roots at the region of the canal; C, widening of the root; D, widening of canal outline on the radiograph. Okay, so answer to this question, please. Okay, do we have more answers? Yes, so amongst the given option, darkening and notching of the root is the correct answer. This is the correct answer. Alright, quickly I have put in a slide to revise Rood and Shehab or Ho and Payton's criteria. Alright, so it includes your darkening of root, your bifid root apex or apical notching, sudden deflection of root, absence of cortical outline of inferior alveolar canal, sudden deflection of canal, narrowing of canal. Alright, so these are your criterias. Fine. Now, amongst these criterias, there are certain high risk criterias. What are those? Darkening of root, absence of cortical outline of inferior alveolar canal, and sudden deflection of canal. Alright, so these are high risk criterias. So amongst this high risk criterias, if two are present, that means the nerve is perforating the root. That means the nerve is passing through the tooth substance. Alright. Now coming to our question number 4. Which of the following statements about temporomandibular joint is false? A, it's a synovial joint. B, it's a gangliomo-arthroidal joint. C, it allows for translational gliding movement. And D, posterior TMJ dislocations are more common than anterior dislocations. So what would be the answer to the question? Yes, more answers. Good. Good, very good. More answers. So yes, the correct answer is posterior TMJ dislocations are more common than anterior dislocations. Okay, this is the answer, because this is the false statement. Anterior dislocations are more common than posterior. That is the correct statement. Alright, so this is the false statement. So yes, it's a synovial joint. This is true. It's a gangliomo-arthroidal joint. This is true. It allows for translational or gliding movement. That is also true. So the false statement is option D. Okay. So the next question: in a long surgical procedure, the best intubation method would be A, nasotracheal intubation with cuff; B, LMA; C, nasotracheal tube without cuff; and D, endotracheal tube. So this question was also asked on our group. I've answered it there, but I wanted to take this up little in detail. That's why I've put this question over here. First, I'd like you all to answer, and then I'll explain a few points regarding this. Yes, keep your answers coming in the comments. More answers, please. Okay. So the answer here is nasotracheal intubation with cuff. This is your answer. Fine. Now, I want you to understand three things. Now, the question over here has just mentioned a long surgical procedure. Alright, it has just mentioned a long surgical procedure. It has not mentioned whether the surgery is regarding maxillofacial region or where we are doing the surgery. This question does not mention. Alright, now let us understand a few things. Now there are two aspects: long surgical procedures, alright, and there are maxillofacial surgical procedures. Okay, there are two things. Now, I have drawn this diagram in my class also. I'm again drawing it here. If this is our trachea, okay, if this is our trachea, and if we have a normal tube without cuff, alright, you have a normal tube without cuff. So this is an uncuffed tube. Fine, this is an uncuffed tube. What will happen now, since this topic tends to be a little confusing for you all because you have not seen intubation practically much at undergraduation level, I understand that, and it's totally understandable. So whenever an intubation happens, when the anesthetist does the intubation, alright, they check for air entry into the lungs. Alright, they check for bilateral air entry. So the bilateral air entry, that means the air entry in both the lungs should be equal. Alright, once they intubate the patient, they check the air entry, bilateral air entry by auscultation, by stethoscope, alright, and then on that particular position where the tube, where they achieve bilateral equal air entry, they fix that tube in that particular position. Alright, they fix that tube in that particular position. Now what happens if it is an uncuffed tube? In a long surgical procedure, what will happen? That the tube might get displaced. Alright, the tube might get displaced in the trachea. It might come out or it might go in further. So what will happen? Okay, I'll just get it checked. Just a moment. We are getting it checked, okay? Just give us 5 minutes. Is it fine now? Is it fine now? Please let me know, students. Is the audio fine? It's okay? You cannot hear me? Okay, we'll check. We'll just check. Wait, please. Please confirm again. Okay, fine. Fine, I'll explain this topic again. I think the audio is fine. So we were discussing cuffed and uncuffed endotracheal intubation. Okay. So I was telling you regarding long surgical procedure and maxillofacial surgical procedure. First we were discussing regarding our uncuffed tracheal tube. Fine. So if we have, I was telling you what the anesthetist does is, the anesthetist intubates the patient, puts the patient under anesthesia, and they check whether the ventilation on both the lungs is equal. Alright, so they hear the lung sounds and the bilateral air entry, that means right and left lung, the air entry should be equal. They check this by auscultation by the use of stethoscope. Now, on the point where the tube, the endotracheal tube has markings, the point where they figure out that this bilateral air entry is equal, they fix the tube in that position. Now what can happen in a long surgical procedure? If it's an uncuffed tube, the tube can displace in the trachea. Either it can come out or go further inside. So in that scenario, what will happen? The ventilation gets compromised. Now let's see what happens in a cuffed tube. Okay, this is your trachea. Okay. This is a cuffed tube. Now what happens in a cuffed tube is, once you inflate the cuff, after you have found out that bilateral air entry on this particular point is absolutely perfect, you inflate the cuff. Alright, so what happens is, the cuff tightly, snugly fits with the walls of the trachea. Alright, so what happens, this cuffed tube will prevent displacement. It will prevent displacement of the endotracheal tube. So it is perfect for your long surgical procedures. Now maxillofacial surgical procedures, most of them are usually long surgical procedures. Alright, most of them are usually long surgical procedures. Now what is happening is, in maxillofacial surgical procedures, what are you doing? You have an endotracheal tube, okay, and you have a cuff. Fine, cuff. Now since you are operating in this orofacial region, what will happen? Some blood, some of your saline irrigation, maybe bone chips, maybe debris will go down the throat. Alright, they will go down the throat. So this blood debris is stopped by this cuff. It is stopped by this cuff. Now if you remember, in the class also I've told you, when we have to extubate the patient, we will deflate the cuff, but once we deflate the cuff, this debris will go further in the trachea. Okay, now for that what do we do? For that we do cuffed endotracheal intubation plus throat pack. Please understand, throat pack again, I am telling you. Okay. So what we do in the throat pack, what we do all around the tube above the cuff, we pack a gauze. Here. Alright. All around the tube. Inside the trachea we pack a gauze. Alright. Also known as tracheal packing or throat packing. Alright. Some books also mention oropharyngeal packing. Alright. They are one and the same thing. Now what is happening? This blood and debris gets accumulated or by the throat pack. Fine. So when you have to extubate the patient, what are you doing? You are removing this throat pack first. Alright, this throat pack is removed first. So once the throat pack is removed, it will get all the blood and debris along with it outside. Alright, so once you have removed the throat pack, you deflate the cuff and then extubate the patient. Understood? So for maxillofacial surgery, a throat pack is a necessity and it is the best. Alright, so cuffed tube along with the throat pack is the best option for maxillofacial surgical procedures. Understood? Okay, now I want to discuss the options. Mostly in maxillofacial surgeries, 99% of the times we are doing a nasotracheal intubation. So here I want to tell you, LMA is not an option. Laryngeal mask airway is for very short surgical procedures. Alright, and like we discussed, nasotracheal tube without cuff is also not an option in long surgical procedures. Now here, please don't get confused. Endotracheal tube. When you say endotracheal tube, it can include orotracheal also and it can include nasotracheal also. Alright, endotracheal can mean either orotracheal or nasotracheal. So endotracheal is your broader term. It is your broader term. Fine. It can include orotracheal also. It can include nasotracheal also. That is why this is not the answer. Be specific. Look for specific things in questions regarding intubation. Monirudha, what is done with nasotracheal? Maxillofacial surgeries? Yes, maximum of the times it is done with nasotracheal and not orotracheal. If there is something in the if something is mentioned in the in your question which contraindicates nasotracheal intubation, then you will go for orotracheal intubation with cuff. Alright, is the doubt clear, Monirudha? And I hope this concept is clear to everyone else also. Please let me know. So is it clear to everyone, intubation, how you have to approach the question? Good. Rest, everyone? Fine. Let's go to the next question. Question number 6. A 25-year-old male presents to the emergency department after being struck in face with a baseball. He has facial swelling, pain and numbness of the cheek on the right side with significant pain and significant limitation in mouth opening. Which of the following facial fractures would you suspect? So option A is Leaford 1 fracture, option B is Leaford 2 fracture, option C is Leaford 3 fracture, and D is zygomaticomaxillary complex fracture. What would be the answer to this question here? your answers, please. More answers? Good. Okay. So, the answer. The answer is option D, zygomatico-maxillary complex fracture. Fine. This is the answer. Alright. Now, please have a look at the question. Facial swelling, pain and numbness of cheek on the right side with significant pain and significant limitation in mouth opening. Alright. That means if there is limitation of mouth opening, that means there is depressed zygomatic arch fracture. That means there is a depressed zygomatic arch fracture. Fine. Alright. So numbness of cheek can definitely be seen in a LeFort-2 fracture, but here the question mentions additional information for you to come at the diagnosis. Is it clear, Alia? I hope you are clear now why it is zygomatico-maxillary complex fracture and not LeFort-2 fracture. Fine. So yes, this is a zygomatico-maxillary complex fracture. Let's come on to our next question. Question 7. A 35-year-old female banker presents with pain and clicking in her temporomandibular joints bilaterally. She also has a history of bruxism. You make a provisional diagnosis of internal derangement of her temporomandibular joints. Which of the following may be the best appropriate measure to manage her condition? Option A is, which of the following may be the least appropriate measure to manage her condition? A is prescription of analgesics, B is provision of night guard, C is recommend chewing gum, D is advise soft diet. So please let me know the answer to this question. Yes, more answers. Keep posting your answers, please. All of you who are viewing, who have joined this live session. Very good. So yes, the answer is recommend chewing gum. This is the correct answer. So if it is an internal derangement patient, we would advise the patient to have rest, alright, because chewing gum is going to lead to worsening of the condition. It is going to cause further fatigue of the masticatory muscles, causing further load or stressing out the joint. So we do not recommend chewing gum to a patient with internal derangement. Okay. Coming to next question, for bupivacaine, which of the following statement? Sorry, that's a typing mistake. Which of the following statement is true regarding bupivacaine? Option A, should be used in patients with liver dysfunction to avoid use of lignocaine. Option B, it is the anesthetic of choice in children. Option C, amongst all local anesthetic agents, it has the lowest risk of systemic toxicity. And D, it is most potent of all amide anesthetics. Alia, what will be the best in terms of what are you asking me? Please ask your question clearly so that I can answer. Good, good. More answers. Are you asking me, Alia, are you asking me that what would be the best treatment for bruxism in internal derangement? Is that your doubt? Please type out the entire statement. Okay. So, yes, for question number 8, option D is the answer. Okay. So, BDS blocks, you answered C. Now, C is a false statement. It is untrue. What is C saying? It is saying amongst all local anesthetic agents, it has the least risk of systemic toxicity. No, this is incorrect. Why? I'll tell you the reason. Because your bupivacaine is a long-acting anesthetic agent. All right. So its duration is longer. It binds to the sodium channels for a longer duration of time. Hence, its chance of systemic toxicity increases. So it has one of the highest potentials. All right. It has one of the highest potentials to cause systemic toxicity as compared to lignocaine and other amide agents. That's why statement C is wrong. I hope that is clear. Your doubt, BDS blogs. Yes. So, Alia, for a patient who is suffering from internal derangement, all right, a patient who is suffering from internal derangement, there is no one particular treatment that is best. There are series of things that we do with a patient: soft diet, night guard, analgesics, anti-inflammatory. If it's not resolving, then maybe arthrocentesis. So that basically what you're supposed to do when is based on what is the clinical presentation of the patient. How restricted is the mouth opening, whether the patient is able to have some mouth opening or not, or whether it is completely restricted. All right. So a series of measures are taken. All right. But if the internal derangement is due to bruxism, then mouth guard is one of the major stays of bringing relief to the patient. Okay. I hope your doubt is clear, Alia. Shall we move on to the next question? Okay, coming to question number 9. Following a surgical extraction of a lower molar tooth, you have closed the flap using a black silk suture. What is the most appropriate time for suture removal? Option A is 1 to 2 days. Option B is 3 to 5 days. Option C is 5 to 7 days. And option D is 7 to 10 days. Okay. So all of you please answer. Good, good. More answers. Yes. So option C is the correct answer. We do suture removal for intraoral sutures between 5 to 7 days. Okay. Coming to our next question. A 45-year-old patient develops an oroantral communication following extraction of her upper left first molar. Following surgical repair of the defect, you provide post-operative advice to this patient. Which of the following will not be included in your post-operative instructions? A is to avoid forceful nose blowing. B is to avoid smoking. C is use of straw to drink liquids. And D, use nasal decongestants. So what would be the answer here? Keep answering, students. Keep answering, keep answering. Yes, good. We will ask the patient to avoid use of straw. Alright. So this is, you will not include this particular thing in your instructions. You will ask them to avoid straw and not use a straw. Alright. So we now have to take care of the sinus also, because we have prepared the oroantral communication and we have to be very careful. So we will ask the patient to avoid using a straw to drink liquids. Coming to our next question, it says identify the instrument, and your options are: option A, stainless steel tongue depressor; B, Weeder's tongue retractor; C, Mold's tongue depressor; and D is 3-hole tongue retractor. So what would be the answer here to question number 11? More answers? Keep answering, all of you. I'll wait for a few more answers. Yes, the correct answer is here, Weeder's tongue retractor. I have shown this also in my image-based session when we have done it. We have done the image-based session on YouTube only. In that I have shown this Weeder's tongue retractor. Alright, so the correct answer is option B. Coming to our next question, a patient presents with deviation of chin to the left side, which is painless. What would you diagnose based on the following radiographs? So the radiographs are given. I'll just shift the radiographs so you are able to view. A is osteochondroma, B is TMJ ankylosis, C is TMJ dislocation, and D is condylar hypertrophy. I'll just shift the radiographs here. What would be your diagnosis? There is deviation to the left side of the chin, and your options are given. Options are osteochondroma, ankylosis, TMJ dislocation, and condylar hypertrophy. Please answer. This is a recently asked question in INI. More answers, please. I had taken this up in my recall session as well. No more answers? Anyone else would like to answer? I'm waiting for 2 minutes. Please answer. Fine. So now this question over here. Alright, there are two things. Fine. Option A, osteochondroma, can also be the answer, and option D, condylar hypertrophy, can also be the answer. Alright, this confusion is very genuine. I'm not denying that. But, okay. Just, I'm zooming out. So, what is happening is, if you see the condylar head and if you see this is your bone scan. Alright, this is your bone scan. Here there is increased tracer uptake. Alright, there is increased tracer uptake. Now you can definitely see the increased tracer uptake in osteochondroma. Alright, but here if you see the condylar head, the anatomy is kind of maintained. Alright, the anatomy of the condylar head is kind of maintained, and there is some overgrowth towards the medial side, but that is also, you know, if you look at the outline there, it is somewhat similar to just an enlarged condyle. Alright, it is somewhat similar to an enlarged condyle. Alright, so if you have to choose between the two over here, given the pictures in the imaging, the best possible answer here would be condylar hypertrophy. Alright, condylar hypertrophy, that means the condyle is growing, its growth has not ceased, there is active bone formation over there. That is why there would be increased tracer uptake, and it will show as a hot spot or a shining scintillating spot on a bone scan. Alright, is it clear everyone? Fine. Now coming to our next question. A 10-year-old child comes after a road traffic accident. On inspection, the child seems normal. However, when you record his vitals, there is evidence of persistent bradycardia and hypovolemia. On CT, there is herniation of orbital contents. What is your diagnosis? A. White eye syndrome. B. Hypovolemic shock. C. Brain herniation. D. Maxillary sinus mucosal thickening. What would be your answer here? What would be the answer to this question? Monir, the deviation is the right condyle is affected. The right condyle is affected and deviation is towards the left side. What is happening in hypertrophy, that the condyle has become enlarged. Condyle has become enlarged. So the lateral pterygoid muscle on that enlarged condyle is having a larger surface area. It's having a larger surface area. So on side of the hypertrophy, the muscle becomes stronger. The muscle becomes stronger than the opposite normal muscle. Alright? Fine. So I have also given you that example in the class. If I lift dumbbells or if I lift weights in the gym only in one hand, so my biceps are going to be stronger only in that hand. Please remember that example and remember this. Okay, yeah, question 13, getting back to question 13. Fine. More answers to question 13. The correct answer here is white eye syndrome. Okay. Now, what cancer are you talking about? See, there are different things. Bony uptake is different and cancer of the soft tissue is different. Please don't confuse between the two. Alright, so osteochondroma is basically a cartilaginous and bony origin overgrowth. Fine. Alright, so it, in case there is a actively growing component, alright, whether it is cancer or whether it is hypertrophy, wherever there would be an active growing component, there the uptake would be more. You will have a brighter spot. Alright. Okay, coming back to this question number 13, white eye syndrome. So I have seen someone answer it as B, hypovolemic shock. No, that is not the correct answer here. Nor is brain herniation the correct answer. This is a classical case of a pediatric orbital floor fracture. Alright. Fracture where there are no clinical signs of injury. Okay, but when you record the vitals, there are signs of a oculocardiac reflex or a trigeminocardiac reflex. Alright. Or a trigeminocardiac reflex. It is basically a triad of hypovolemia, that is decreased BP, bradycardia, that is decreased heart rate, and nausea and vomiting. Alright, how this reflex happens, you don't need to go into the details, you just need to remember this triad. Okay, I think in one of my previous YouTube sessions also explained where there was a similar question. Understood? Why is this not hypovolemia and why this is not just herniation? Alright, so every orbital floor fracture has a chance to be associated with an oculocardiac reflex. Alright. Now coming to question number 14. Nasopharyngeal airway should not be used in cases of hemorrhagic disorders. Option A. Option B, patient on anticoagulants. Option C, patients of basilar skull fracture. And option D, all of the above. Yeah, so if hypertrophy is happening, alright, mostly if you see the entire condylar head, mostly the condylar head enlarges in condylar hypertrophy. Alright, the head part enlarges. So if you see grossly at that image given over there, the head is with what is outgrowing the confines of the glenoid fossa. Alright. More answers for question 14. Any more answers? Okay, so the correct answer here is all of the above. All right. This is the correct answer here. All of the above. All right. So basically, the nasopharyngeal airway is going to encounter your nasal mucosa. All right. Nasal mucosa is very thin. Okay, and it is highly vascular also. Fine. So if patients are suffering from any hemorrhagic disorders, or if they are on anticoagulants, we try to avoid a nasopharyngeal airway. Basilar skull fracture, definitely we are going to avoid a nasopharyngeal airway, there's no doubt about it. But in addition to that, if a patient is on anticoagulants, is on blood thinners, or if there are hemorrhagic disorders that the patient is suffering from, we will again avoid a nasopharyngeal airway. Alright, because nasopharyngeal airway does tend to cause trauma. It will definitely cause trauma, which can lead to bleeding, which might get difficult to control. Alright, is it understood, all of you, this question? Coming to the next question, question 15. What type of bone healing is seen with lag screws? Healing, option A, healing without callus formation. B, healing with callus formation. C, there is no effect on healing. And D, we cannot say what kind of healing it causes. So please let me know the answer to question number 15. More answers? More answers, please. Yes, so the correct answer is healing without callus formation. Healing without callus formation. We all know lag screws come under compression osteosynthesis. We all know. Okay, so in compression osteosynthesis, what is it? There is no callus formation. There is no callus formation in compression osteosynthesis. All right. Now we are coming to the last question for today's session. Question 16. Which of the following statements regarding Leaford fractures is not true? Option A. Leaford 1 fractures are horizontal fractures of maxilla passing below the infraorbital rim. Option B. Leaford 2 fractures are pyramidal fractures of the maxilla that extend through the frontonasal region, infraorbital rim and maxillary buttress. Option C. Leaford 3 fractures are craniofacial fractures involving the midface and ethmoid sinuses. D. All Leaford fractures involve fractures of the zygoma. So what would be the answer to this question? More answers? This is our last question. Quickly give me answers. So yes, the correct answer is all fractures involve fractures, all Leafoot fractures involve fractures of the zygoma. This is your correct answer. Okay, because Leafoot 1 and Leafoot 2 do not cause fracture of the zygomatic arch. Alright, Leafoot 2 will definitely pass through the zygoma bone, but it won't cause fracture of the zygomatic arch. Alright, and again, Leafoot 1 is a subzygomatic fracture, if you all remember. So all Leafoot fractures involve fracture of the zygoma. This is false statement. This is not true. Alright, so option B, you have answered, field the dentistry. Leafoot 2 are pyramidal fractures of maxilla that extend through frontal nasal region, infraorbital rim and maxillary buttress. This is a correct statement. That is how a Leafoot 2 line travels. From the frontonasal region, it may or may not involve the frontonasal suture. Then it travels medially. It travels to involve the medial wall of the orbit. Then it travels inferiorly, involves the infraorbital rim, may or may not involve the infraorbital foramen, and goes and involves the maxillary buttress, and posteriorly it causes fractures of the pterygoid plate. Alright, is it clear? Okay, is it clear? So with that we wind up the session. Okay, I hope this session was useful to you all. So you have 1 month and 1 week remaining. 1 month plus 1 week remaining for your exam. You all are doing well. Alright, you don't need to panic. Alright, please read your questions carefully and then attempt. And now is your time to revise, give a test, revise, give a test, revise, give a test, revise, give a test. Increase your frequency of doing questions now. Alright, so with that, thank you so much. All the best, dear students. Happy studying.